Good day, everyone. We are Group 9 and we are here to present our scientific poster based on the research journal assigned to us under Respiratory and Gas Exchange. Before we start our main discussion, let us know the features we will discuss today. First, we have the title of the research study. This will be followed by the introduction, which includes the objectives of the study. Then the methodology, or the main methods used in the study. We will also have the results and discussion. And finally, the conclusion. Hopefully by the end of the video, you already know the key information for this research journal.
As stated earlier, this scientific poster is based on a research journal assigned to us, which is entitled Smoking, Smoking Cessation, and Lung Cancer in the UK since 1950, combination of national statistics with two case control studies. Now, let us begin with the introduction. Here we have a short description or background about the main focus of the study. And of course, this also includes the objectives of the study. Smoking has long been connected to a number of diseases, including lung cancer. And cigarette smoking was very common among men and then women in the UK at the beginning of the 20th century. Consequently, this study links the findings about smoking, quitting smoking, and lung cancer from two significant case control studies of smoking and lung cancer in the UK. The studies were done 40 years apart, the first in 1950 and the second in 1990. As you can see from the poster, the purpose of this study is to examine the long-term effects of quitting smoking at various ages, as well as smoking status and the cumulative risk of dying from lung cancer by the age of 75. So keep listening because we'll talk about these topics later. A flowchart was used in the poster to clearly summarize the methods used in the journal. The 1950 study and the 1990 study, two case control studies, were linked in this journal as we said earlier. Let's start by talking about the participants and research methods used in each study. From 1948 to 1952, the 1950 research was carried out in London and four other surrounding towns. Interviews were also used in this study to acquire data. The 1990 survey, on the other hand, was carried out in southwest England areas not included in the 1950 study from 1988 to 1993. It also conducted interviews to gather data, much like the 1950 study. Let's talk about the cases and controls that were employed in both studies. Patients suspected of having lung cancer who are under 75 make up the cases in both studies. In contrast to the 1990 study's 667 men and 315 women cases, the 1950 study contained 1,465 cases. The two investigations, however, used various controls. Age-matched hospital patients with a variety of different disorders were present in the 1950 study. There were also 1,465 controls in total, while participants in the 1990 study were matched to patients with probable lung cancer in terms of age, sex, and general location of residence. The controls in the 1990 study were also divided into two, population control and hospital control. It had a total of 2,108 male and 1,077 female controls. Now we can proceed to the statistical methods used in the study. First, for the relative and cumulative risk, the odds ratios employed in the 1950 study were based on published frequency distributions of age-matched cases and controls. Contrarily, the 1990 study employed logistic regression with age adjustments. The national lung cancer mortality rates from 1950 to 1990 were then combined with these. The cumulative risk by age 75 was calculated by multiplying the relative risk from the 1950 research by 0.6 in men and 0.5 in women. In the 1990 study, absolute lung cancer rates for various smoking categories within a single age group were calculated by averaging the relative risk over all ages for each smoking category. The outcomes of all these procedures were combined to produce the study's final results.
For the results, Figure 3 shows the effect of cessation in the 1990 study. A large number of men and to a lesser extent of women had stopped smoking well before 1990. Hence, particularly for men, robust estimates can be obtained from the 1990 data of the effects of prolonged cessation on the avoidance of risk. Here, the ratio of risk of lung cancer in those who have stopped smoking to that in continuing smokers gets progressively lower as the time since cessation gets longer, although it never gets quite as low as in lifelong non-smokers. The cumulative risks by 75 years of age are 15.9% for men who continue to smoke cigarettes, and 9.9%, 6%, and 3%, and 1.7% for those who stopped around 60, 50, 40, and 30 years of age. The pattern among women was similar, wherein the cumulative risk of lung cancer by age 75 among continuing smokers was 9.5%, compared with 5.3% and 2.2% among women who stopped around 60 and 50 years of age respectively. Now, on to the comparison of findings for smoking in 1950 and 1990 studies presented in Table 2. There were two clear changes observed, namely the changes in prevalence of smoking and changes in lung cancer rates among continuing speakers. For the changes in prevalence of smoking, one clear difference between the 1950 and 1990 study results in Table 2 is that many of the controls in the 1990 study had given up smoking. So there was a large decrease in the prevalence of smoking between the two studies. For the changes in lung cancer among continuing smokers, it is said that the cumulative risk of lung cancer among smokers increased substantially. The increase occurred not only among women, wherein the cumulative risk for cigarette smokers was 1% in 1950 and 9.5% in 1990, but also among men, wherein it increased from 5.9% at 1950 cigarette smoker lung cancer rates to 15.9% at 1990 rates. As lung cancer mainly occurs above the age of 55, the increase in the cumulative risk is mainly because current smokers, aged 55 to 74 in 1950, were less likely to have smoked a substantial number of cigarettes throughout adult life than current smokers in 1990.
The discussion tackles two main ideas: the effects of prolonged smoking and prolonged cessation. Men and women from the 1990 study have been smoking for a substantially longer amount of time in their adult life compared to those who smoked in 1950, which is why the risk for lung cancer recorded in 1950 was lower compared to the risk recorded in 1990. It is seen that even after the changes in cigarette composition, risk for death before age 75 due to lung cancer did not decrease. For women who were current smokers, lung cancer mortality risk rate would have only been 1% in 1950 and 10% in 1990. For men, the rates would be 6% in 1950 and 16% in 1990. Stopping allows the avoidance of the majority of the risk even if one ceased smoking at 50 or 60 years of age. Those who stop at age 30 avoid more than 90% of the risk attributable to tobacco. Despite other attempts such as switching to other forms of tobacco or lessening the amount of cigarettes smoked, the most effective way to limit risk is to still stop smoking. To conclude, these are the findings from the study and some insights into the future. The cumulative risks by 75 years of age are 15.9% for men who continue to smoke cigarettes, and 9.9%, 6%, 3%, and 1.7% for those who stopped at around 60, 50, 40, and 30 years of age. Changing smoking habits does not have a significant effect on risk, but completely stopping smoking, especially at a younger age, has a substantial effect even after doing it for years. Rates on death caused by tobacco during the first half of the 21st century will be largely determined by the smoking habits of current smokers, and rates during the second half will be determined by habits of new smokers.
And that ends our report for the scientific poster for the study Smoking, Smoking Cessation, and Lung Cancer in the UK since 1950, combination of national statistics with two case control studies. We hope that we were able to explain the long-term effects of quitting smoking at various ages, as well as smoking status and the cumulative risk of dying from lung cancer by the age of 75. With the data of the study presented, we also wish that we have shown the importance as to why people should not smoke. Again, we are Group 9. Thank you so much for listening and have a blessed day.